Hi, so my name is Duy Luu. I'm a PGY1 Nutrition Support Pharmacy Fellow. My grand round topic for today's presentation will be clinical application of intravenous lipid emulsions in adult patient care. My advisor and I do not have anything to disclose. The objective for today's presentation will be defining characteristic of intravenous lipid emulsions, or I will refer to as IOE for the rest of this presentations, recognize the benefit, potential complications, and clinical application of intravenous lipid emulsions, and lastly, we will review the best practice for IOE administrations. So what is intravenous lipid emulsions? Intravenous lipid emulsion is a sterile, non-pyrogenic, wide homogeneous solutions intended for intravenous infusions. It serves as a source of calorie and provides essential fatty acid for patients who require nutrition who cannot get it through oral enteral routes. The emulsion is composed of various sources of oil, including soybean, fish, safflower, MCT, which include coconut and palm kernel oil. Research for IOE as nutrition therapy began as early as 1712 when olive oil was infused into dogs. These dogs died a couple hours later due to acute respiratory distress caused by fat embolism. In 1873, a Canadian doctor infused milk into 3 malnourished cholera patients, but only 2 survived. This further proved the theory that unmodified fat cannot be infused intravenously. In 1955, cottonseed oil was introduced in the US, but it was withdrawn several years later due to severe side effects, including fever, jaundice, chill, vomiting, and bleeding. After several years of trial and error, in 1962, a Swedish physician and nutritionist researcher found that soybean emulsion, when mixed with 8-phospholipid used in emulsifying agents, can be safely infused into patients. And finally, in 1975, the first soybean emulsion was approved for clinical use in the US. As IOE development has continued to evolve, provided various types of formulations. Following the development of first generation soybean oil, the same company developed different concentration, increasing from 10 to 20 to 30. And in 1993, another company created a similar product using soybean oil and added another agent called sodium oleate. Only a decade later, a third generation of intravenous lipid emulsion come out, incorporating olive oil into soybean oil. The reason behind this development was that they want to lower the soybean content in this intravenous lipid emulsion, and also added another agent called alpha tocopherol. 2 years later, another product by another company gained FDA approval in 2016 that blended 4 types of oil, including soybean, MCT, olive, and fish oil. The reason behind this development was that they want to optimize the omega-6 to omega-3 ratio and also increase the concentration of alpha tocopherol. And lastly, in 2018, another product gained its FDA approval. This was the intralipid emulsion containing only fish oil. It was approved only for pediatric use for the treatment of PNAC, which is parenteral nutrition associated cholestasis. This chart here is just to show the general information of various formulations of IOE available in the US, which we'll go into detail in the next few slides. So as shown in the red box, the source of oil varies from each formulation in the chart, with the percentage concentration of each sort differing throughout. The orange box, which is the third generation oil, consists of olive oil with soy oil. As I mentioned before, the development of this product was to decrease the concentration of soybean. Thus, only 20% of soybean was included in this formulation, and the remaining 80% was from olive oil. In the purple box is the first generation, which is only soybean oil, with 2 manufacturers making this product. In the green box, that's the fish oil that was developed, getting FDA approved for pediatric use only. And in the blue box, this is the highlight the full oil of IOE, which explain all the sources of the oil. In the red box are the additives including each lipid emulsion, each serving a different function. As I mentioned that through the timeline that we have seen before, a phospholipid was used in emulsifying agents that help to disperse the oil into liquid phase, increase stability of IOE, also making it safe for patients to be used. Glycerins help lipid emulsion achieve its isotonicity and add additional calorie, thus making the IOE 10 kilocal per gram instead of 9 kilogram cal per gram obtained from fat obtained from diets. The third ingredient, alpha tocopherol, is a bioactive form of vitamin E that acts as an antioxidant protecting the liver from oxidative damages. The last additive, sodium oleates, help maintain IOE pH between the range of 6 to 9. This is specified by the USP Chapter 729. Since IOE are derived from various sources, pharmacists must take into consideration of the potential allergic reactions. If patients have any hypersensitivity to eggs, all IOE formulation must be avoided. If patient allergic to soybean, all soybean formulation contained should be avoided. And if patient have peanut allergy, soybean formulation should also be avoided as cross-contamination between the two have been reported. Similarly, the fourth generation IOE should be avoided in patients with fish and potentially shellfish allergy. Patients with coconut allergy should also avoid the full oil blend. The last component that are listed here is the phytosterol. Phytosterol are derived mainly from plant, especially the soybean. Thus, this is high concentration of phytosterol in soybean, leading to elevated total bilirubin level and reduced bile acid production, thus ultimately impair fat breakdown absorption in patient that's critically ill. Now, in patient that's healthy, phytosterol can also help to reduce triglyceride in these patients. Each oil contains varying amount of fatty acid. The fatty acid highlighted in the box indicate the concentrations, which will be explained in more detail in the next slide. So there are two types of fatty acid. One is essential, which is known as polyunsaturated, and the other one is non-essential fatty acid, which is known for monounsaturated. The polyunsaturated fatty acid is composed of two omega-3 and omega-6. Omega-3 is known for its anti-inflammatory effects with a source derived from soybean oil and fish oil. One type of omega-3 is alpha-linoleic acid, which is the downstream product of EPA and DHA. On the other hand, the omega-6, which is another essential fatty acid known for its pro-inflammatory effects, have a type, this is linoleic acid, with a downstream product of arachidonic acid. This is one of the components that used to diagnose essential fatty acid known as PFAT. This will come important later on in the slides. On the other side is a non-essential fatty acid. This cannot be made in the body. Unlike the essential fatty acid, it's composed of omega-7 and omega-9. Omega-7 source derived mainly from fish oil with a type called palmitoleic acid. The omega-9 source consists of soybean oil and olive oil. The type of omega-9 is oleic acid with a downstream product of meat acid. Meat acid is the second component used to diagnose essential fatty acid deficiency. The omega-6 to omega-3 ratio in the bottom red box is calculated based on the content of the top green box. This ratio is significant because the lower ratio can promote less inflammation and less immunosuppressive effects. Aspen currently recommended a ratio between 2 to 1 and 4 to 1. Looking at all these formulations, the most optimal ratio that can be seen here is the full oil blend, which is 2.5 to 1. This slide illustrates a comparison of omega-6 to omega-3, demonstrating the benefit of omega-3 and omega-6. During a traumatic injury where the body initially responded by releasing inflammatory mediator, but then transitioned into anti-inflammatory and immunosuppressive state. This state can be worsened by the introduction of omega-6 into the body, highlighted by the dark arrow, and mitigated by omega-3, highlighted by the white arrow. This is important when it's coming to critical ill patients, as this can help to pick out which formulation is best fitted for the patients. Most of the IOE on this chart shown is a 20% concentration, providing 2 kilocal per ml, whereas the FOIOE highlighted in the green box is the only one available for 10%, which is why it's 1.12 kilocal per ml. Now let's come to assessment time. The first question is, which of the following fatty acids are considered essential? Is it A, omega-3, B, omega-6, or C, omega-9, or D, A and B? For virtual participant, please feel free to type out your answers. How many people pick A? Some people pick B, C, or D. That's the correct answers. So omega-3 and omega-6 consider essential fatty acid, and omega-7 and 9 are non-essential fatty acid. Now that we have reviewed the characteristic and discussed the various formulation of IOE, let's go over its indication and clinical usage. Most IOE, except for FOIOE, is approved for both pediatric and adult usage to provide calorie and prevent essential fatty acid deficiency in parenteral nutrition. Additionally, it can be used off-label as a treatment for adults in receiving overdose of lipophilic drugs, such as local anesthetic, beta blocker, calcium channel blocker, diphenhydramine, tricyclic antidepressants, and cocaine. This table summarizes the aspirin recommended dose for various IOE based on the patient clinical conditions, including the maximum dose and infusion rate for each formulation. Within the green box are the adult recommended dosage for patients based on their clinical conditions. With the stable dose, the dose usually range between 1 gram per kilogram per day to 2 gram per kilogram per day, depending on the formulations. As for critically ill patients, aspirin recommended a dose of soy oil of less than 1 gram per kilogram per day. There was no recommendation for the dosage in olive oil and the other formulations. For the maximum dose and maximum infusion rate, it is similar for all three formulations, with the maximum dose of 2.5 gram per kilogram per day and the maximum rate of 0.11 gram per kilogram per hour. On the other box is the FOIOE that we have discussed is only FDA approved for pediatric use. Thus, the maximum dose and infusion rate here is based on pediatric recommendation. As mentioned earlier, essential fatty acids play a critical role in preventing essential fatty acid deficiency. The risk factors include PN-dependent patients who do not receive a minimum dose of IOE, as well as high-risk patients that have impaired digestion, absorption, or metabolism, such as patients having malabsorption syndrome, cystic fibrosis, pancreatic insufficiency, enterocutaneous fistula involving the small bowel, inflammatory bowel disease, and carnitine deficiency. EFAT is diagnosed when T-to-T ratio is greater than 0.2. This is a Hohmann index comparing the meat acid to arachidonic acid, which we have mentioned earlier, between the omega-6 and omega-9. It's a comparison of triene to tetraene or T-to-T. The physical sign and symptom that you can see with EFAT would eventually be alopecia, eczematous dermatitis, growth retardation, hair depigmentation, and poor wound healing. Biochemical sign and symptom would include hyperlipidemia, thrombocytopenia, and elevated liver function tests. Monitoring for every 3 to 4 months for high-risk patients and for 1 to 2 times annually for chronic home PN patients. This chart outlines the aspirin recommendation for minimum IOE dose required to meet the essential fatty acid requirement for daily use. This is based on linoleic acid. As indicated in the red box, soy IOE has a lower daily linoleic acid requirement compared to the newer generation IOE, which require 3 times the amount. This is because the majority of linoleic acid is coming from soybean oil. For instance, per 1,000 kilocalorie daily total calorie required, only 4.1 gram of soy IOE is required, whereas the other formulation required 12.3 to 12.6 gram. So as a general rule, we need at least 4.1% of total calorie or 12.5% based on the IOE product to meet essential fatty acid requirement. Okay, this brings us to the second assessment questions. Which of the following T-to-T ratio would determine essential fatty acid deficiency? Is it when T-to-T is greater than 0.2, or T-to-T is less than 0.2, or is it when T-to-T is greater than 0.4, or is it less than 0.4? Our virtual participant, please type out your answer when you're ready. How many people pick A? How many people pick B, C, or D? The answer is A, is when T-to-T is greater than 0.2. So these are the adverse event and complication that can be associated with IOEs. Just like any other medications, there are always adverse events. One of the adverse events is hypertriglyceridemia. Another adverse event is fat overload syndrome, pancreatitis, intestinal failure associated liver disease, and other potential complications such as hypercoagulation, looking to be caused by phylloquinone, that are derived from sources like soy and safflower oil, which may continue to increase clotting. This is really important in patients taking anticoagulation medications. Another potential adverse effects associated with IOE is the pulmonary compromise. When IOE is infused at high dose, this can disrupt icosanoid balance, thus leading to decreased arterial oxygenation and potentially leading to pulmonary complications. IOE can also increase the risk of infection due to their unique, slightly alkaline pH and isotonic nature. This provides an optimal environment for bacterial growth. Furthermore, they also contain omega-6, which increase the risk of inflammation and immunosuppressions. Let's start with IOE-induced hypertriglyceridemia. Hypertriglyceridemia is diagnosed at triglyceride level greater than 400 milligrams per deciliter. Would the etiology stem from high dose of IOE greater than or equal to 2.5 grams per kilogram per day, or the infusion rate greater than 0.11 gram per kilogram per hour? This can also be due to additional lipid emulsion medications such as propofol, a 10% lipid emulsion providing 0.1 gram of fat per ml, or clevidipine, which is another 20% lipid emulsion providing 0.2 gram of fat per ml. Complications of hypertriglyceridemia include fat overload syndrome with symptoms such as icterus, acute respiratory distress, metabolic acidosis, bleeding, and hepatosplenomegaly. Hypertriglyceridemia can also induce pancreatitis in patients at triglyceride level greater than 1,000. Although this number is controversial across various studies because pancreatitis can also be diagnosed using amylase and lipase. For monitoring, for inpatient, we want to measure triglyceride at baseline and then weekly. For outpatient, we measure triglyceride also at baseline and then monthly. Sign and symptom of hypertriglyceridemia would include headache, fever, jaundice, and abdominal pain. The treatment and prevention of hypertriglyceridemia is based on the triglyceride level. At triglyceride level more than 400 milligrams per deciliter, we want to reduce IOE dose, raise, and cycle the PN between the 12 to 18 hours, giving the liver rest. We also want to reduce IOE frequency from daily to every other day or 2 times a week. At triglyceride greater than 600 milligrams per deciliter, you want to hold IOE infusion. And you can only resume IOE once the triglyceride level falls below 400 milligrams per deciliter. Consideration should also be taken when holding IOE for more than 7 to 10 days, as this could potentially lead to complications such as essential fatty acid deficiency. Next, let's talk about intestinal failure-associated liver disease. To diagnose IFOD, or intestinal failure-associated liver disease, the criteria include gamma-glutamyl transferase, or GTT, greater than 5 times upper limit normal, alanine aminotransferase, or ALT, more than 2 to 3 times upper limit normal, or total bilirubin 2 to 3 times baseline. There are others liver enzymes that we are not using because they are non-diagnostic, they are non-specific diagnostic marker. They can be high and elevated, but that does not necessarily mean it's liver injury. PN-associated etiology would include chronic PN use for more than 3 months and no frequency of PN therapy. Vitamin E deficiency, high level of phytosterol and omega-6, glucose infusion overload greater than 5 milligrams per kilogram per minute. IFOD complication includes steatosis, cholestasis, cholelithiasis, and hepatic fibrosis. Monitoring of IFOD would include liver enzymes such as bilirubin, ALT, AST, and ALP. We also need to evaluate for overfeeding. That means like hypertriglyceridemia. We want to look out for the high dose and high infusion rates. Symptom of IFOD would include jaundice, pruritus, dark urine, and right upper quadrant pain. Coagulation parameters also need to be measured as thrombin are made in the liver. Prothrombin time and activated partial thromboplastin time should be measured. For IFOD prevention and treatment, there are two types. There are PN intervention and EN interventions. For PN intervention, you want to cycle the PN like hypertriglyceridemia. You want to cycle it between 12 to 18 hours. You want to avoid overfeeding. Avoid giving glucose infusion rate more than 5 milligrams per kilogram per minute. You also want to limit the soy IOE to less than 1 gram per kilogram per day. You also want to consider alternative IOE formulation. As for enteral nutrition intervention, you want to introduce enteral feeding as soon as possible so that will reduce the PN dependency and also preserve liver functions. Now that we have learned about the characteristics and different formulation of ILE and its potential side effects, let me meet our patient CC. So patient CC is a 66-year-old female who underwent robotic esophageal myotomy with fundoplastic in February 2020 for symptomatic achalasia. Her post-operative course was complicated by a small bowel injury, necessitating multiple exploratory laparostomy and extensive small bowel resections. This resulted in short bowel syndrome with 80 centimeters of small bowel remaining, and a total colectomy with an end jejunostomy. Parenteral nutrition was initiated at an outside hospital and continued for several months. She was later referred by her surgeon to Dr. Galloway and our nutrition support team for ongoing PN management. This slide presents the patient vital sign along with a calculated basal energy expenditure. At the outside hospital, the patient was started on 2-in-1 PN formulation, running continuously for 24 hours, providing 1,873 calories. This meets the patient total kilocalorie requirement. The PN composed of 78 grams of amino acid and 312 grams of dextrose, with the SOIOE 50 grams infused separately over 12 hours. All doses align with ASPEN recommendations. So after starting PN at the outside hospital, patient CC continued with home PN, and these lab results were recorded after the patient had been on PN for 3 months. On the left side, you can see the progression of liver enzyme in relationship to the lipid injectable emulsion, with the y-axis measuring the unit of the enzyme that we measure, and the x-axis is the month the patient had been on parenteral nutrition. This layout will be the same for the rest of the presentation. On the right side is the total bilirubin in relationship to lipid injectable emulsion. So on the left side, you can see the ALP and AST level rise 3 to 4 times the upper limit of normal, and ALT twice the upper limit normal. On the right side, you can see the total bilirubin was 9 times baseline. So recognizing the elevation in patient liver enzyme, the provider at the outside hospital adjusted nutrition therapy plan in accordance with ASPEN recommendations by cycling the PN from 24 hours to 14 hours, reducing the lipid content from 25 to 25 grams from 50 grams, and reduce the frequency to given every day to only Sunday, Tuesday, and Thursday. Additionally, the provider incorporate enteral feeding to patient nutrition plan. The plan are dosed appropriately based on total energy expenditure requirement. After the changes were implemented, the patient liver function showed improvement over the following 2 months, as shown in the both graph. However, 2 months later, the patient liver enzyme progressively worsened, as illustrated in both graph. The outside hospital surgeon then referred the patient to our team for PN management. The NSD team then investigated other potential causes of liver dysfunction. This would include sepsis, inflammation, excessive energy intake, excessive IOE dose, exceed the maximum infusion rate of IOE, high ratio of omega-6 to omega-3, and low content of vitamin E and higher concentration of phytosterol. Well, looking at patient condition, there were no evidence of sepsis and no other significant factor contributing to inflammation. All the prescribed dose infusion rate from the outside hospital were appropriate according to ASPEN. And therefore, the only 2 modifiable factors that we can see here is the high ratio of omega-6 to omega-3 and low content of vitamin E and high concentration of phytosterol. According to the literature, there are various studies support the use of full oil IOE over SOIOE or soybean IOE for PN. One such study is a randomized controlled double-blind multi-center study designed to evaluate the safety and tolerability of full oil IOE in patients with intestinal failures receiving long-term parenteral nutrition. Conducted over a 4-week period, the study included 73 patients. This is the result of the study. The data in the green box display the change in liver enzyme from baseline after 4 weeks using full oil IOE, while the data in the blue box represent the outcome of SOIOE. Although ALT was the only liver enzyme with statistically significant change, the overall benefit of full oil IOE is evident by the downward trend of other liver enzyme after 4 weeks of use. Most of the result that we can see here is non-significant, possibly due to the small sample size of 73 patients. No adverse events were reported, and the study concluded full oil IOE was safe and well tolerated by patients and showed potential benefit in improving liver enzyme. The next study was conducted internally at EUH by Dr. Lawrence, which is one of our former NST residents. The objective of this case control chart review was aimed to assess the safety and tolerability of full oil IOE following a switch from soybean. There was a single center retrospective case control chart review involving 26 patients who served at their own control, comparing the outcome before and after the transition from soybean to full oil IOE. Both formulation was administered at similar dosage, which is 0.97 gram per kilogram per day, plus or minus 0.4 grams, over an 8 weeks period. So this is the result of that data. The graph on the left compared the total bilirubin level after the initiation of soybean and full oil IOE. The results saw a significant reduction in total bilirubin after the transition from soybean to full oil. Similar to previous study, although not most enzymes shown clinical improvement after switching from full oil, only AOP was statistically significant as demonstrated on the right chart. This is expected, given that the review was retrospective with missing data and involved a small sample size. There were no reported adverse event or sign of EFAT. The review highlighted the clinical benefit of full oil IOE in patients comparing to soybean IOE. Now let's get back to patient CC. So based on the clinical evidence, our team initiated nutrition optimization for patients by transitioning from the IOE, SOIOE to full IOE for 5 days per week. The patient continued with cycling PN and 2 feeding overnight for 2 days per week based on patient tolerance. All those were appropriate and shown adequate total kilocal. So after we transition the patients to full oil IOE, the patient ALP, AST, and ALT level improved over the first 2 months, but then it fluctuates and rose over the next 8 months. This is due to the potential risk factors, such as sepsis, shortage of the full oil IOE that require us to change to soybean IOE, and other complications. Eventually, this problem was resolved. From month 17 to month 20, the liver enzyme improved, though they began to rise again shortly after. This table shows the progression of total bilirubin, which follow a similar trend as displayed in the previous chart, except that total bilirubin continued to decrease after the 20 months. Despite its continued to trending down, the level is still 7 times from its baseline. Does the surgeon express concern about the prolonged elevation of liver enzyme and consult our team for alternative approach or modifications? This led us to explore other IOE options such as fish oil. Since we have talked about it earlier, fish oil was only FDA approved for pediatric use, and fish oil was actually approved in Europe prior to being FDA approved in the US. It was approved in 1998. So there are more data for pediatric use and adult use. However, there was one case control retrospective case report for a patient that get approval for compassionate use of FOILE under an emergency investigational new drug protocol. The patient served at their own control, and the objective was to evaluate whether FOILE monotherapy can reverse IFAL in chronic PN patients. The duration of the study of the report was from September 2010 to December 2011. Patient was originally started on soybean with 40 gram over 12 hours, then transitioned to FOILE dose of 45 gram over 16 hours. Following the transitions, the patient's symptom improved within the first 4 weeks, with previous complaint of nausea, vomiting, and diarrhea resolved. By week 5, total bilirubin and C-reactive protein, known as CRP, which is an inflammation marker, had decreased threefold. As shown on the left chart, this is expected due to the anti-inflammatory effects of omega-3, which is in fish oil. Similarly, the reduction in ALT and AST were observed in the right graph. Although ALP initially increased, it ultimately decreased to a stable pretreatment value. No significant adverse events were recorded, and the case report suggests that FOILE can potentially reverse IFAL in adult patient on chronic PN. Like I said earlier, because FOILE was only approved for pediatric use, a systematic review and meta-analysis was composed with a design to evaluate FOILE monotherapy, therapeutic effects in reversing and preventing PNAC. This compiled 36 studies, but only 7 studies meet its inclusion criteria, with 4 studies used for PNAC preventions and 3 studies used for PNAC reversal. The forest plot for PNEC prevention study on the left showed no significant result at the confidence interval included 1. This was anticipated as FOIOE was not expected to cause PNEC. In addition, the result of PNEC reversal shown in the right charts was significant, highlighting the efficacy of FOIOE in reversing PNEC in infant requiring long-term PN. There were no significant adverse effects reported. The outcome was supported the use of FOIOE monotherapy in reversing PNEC for neonates requiring long-term PN. After the meta-analysis and the systemic review, the more recent study is a retrospective case study that was done in Korea. It was focused on 2 infants diagnosed with IFAL. It was a retrospective case series designed to evaluate whether FOIOE monotherapy can reverse IFAL cholestasis in pediatric patients previously treated with full oil. Eventually, both patients were initially placed on full IOE with the dose reductions based on the liver enzyme. Eventually, when IFAL was diagnosed, patient IOE was switched from full oil to the fish oil IOE, as shown in the chart on the right. IFAL was resolved in both cases. It was within 14 to 22 weeks after the fish oil treatments, as calculated from the data in the red box. For both cases, most liver enzyme and triglycerides shown in the red box improved after usage, except for AST and ALT in case 2. There were no report of adverse event in both cases, demonstrate that FOIOE monotherapy can safe and can potentially reverse IFAL in infant receiving chronic PN. Now let's get back to patient CC. Based on the pediatric data demonstrating the benefit of FOIOE in patients with liver injury, our team initiated a trial administering 50 grams of FOIOE for 12 hours for 3 days for patients while maintaining the full IOE for 1 day. This is to ensure adequate essential fatty acid intake. With the incorporation of the fish oil into the PN plan, the patient liver enzyme AST and ALT level significantly decreased and remained stable at normal limit. Similar to previous K report, the patient ALP continued to fluctuate and never returned to normal limit. The total bilirubin also returned to normal baseline for patient in approximately 8 weeks since the start of fish oil ILE. Patient is still receiving care with the NSC team and remains stable. Now that we have finished the patient case, let's discuss the last objective for this presentation, which is the best practice and recommendations. The best practice and recommendation that will be discussed will include 3-in-1 versus the 2-in-1 PN, the filters, the stability and destabilization phase, compatibility, ongoing monitoring, and shortage management per aspirin. For the 3-in-1 PN, it may be infused over 24 hours, and for the 2-in-1 PN with IOE infused separately, it may be infused over 12 hours. This is according to the CDC guideline. Regardless of whether it's 3-in-1 or 2-in-1 with IOE, at 1.2 microns should be used. It is not to prevent bacteria, but to prevent aggregate and fat globule from entering the patient body. We should also be using BHP-free tubing, as this prevents bleaching. Now, next we'll discuss the factor that can influence the stability of IOE. First, let's start with zeta potential. Zeta potential is a measure of the electrical charge on the surface of lipid droplet. A higher zeta potential indicate better stability due to stronger repulsive force between droplet. Additives that alter the ionic strength or pH can reduce the zeta potential and destabilize the emulsion. PFAT5, which refers to a percentage of fat, percentage of fat greater than 5 micron. It is according to the USP Chapter 729 that for all lipid injectable emulsion, it should not exceed 0.05%. This is to ensure the safety and stability of the emulsion, because large fat globule can accumulate in the pulmonary, capillary, liver, and potentially leading to complications such as fat embolism and impaired organ dysfunctions. Oxygen is another factor that can influence IOE, as exposure to oxygen can lead to oxidation of lipid, forming lipid hydroperoxide that compromise the emulsion stability. Packaging an oxide-tight container and protecting from light can mitigate this risk. Additives such as electrolyte, vitamins, and trace element can affect the stability of IOE by bringing in parts of the charge, such as calcium, magnesium, which can neutralize the negative charge on the lipid particle, leading to instabilities. Emulsifiers. The primary emulsifier that we have been discussing since the history of IOE was the 8-phospholipid that was used. The main purpose of it is to ensure stability by impart a negative charge on the lipid particle, preventing coalescence, which I will explain in more detail in the next slide. Temperature can also accelerate degradation of lipid emulsions. Stability is generally preferred in the lower temperatures, such as refrigeration. This can extend the shelf life of the emulsions. IOE pH is mostly generally stable at 7 to 8. IOE destabilization occurs in multiple phases. The phases contained within the orange box include aggregation and creaming. You can either redisperse with gentle agitation and use safely with these two phases. Aggregation is the process where dispersed droplets come together without fusing, often remaining too small to be seen with the naked eye. Creaming refers to the formation of a layer of aggregate droplet at the surface of the emulsion. This can settle at the bottom. The red box highlights the coalescence and oiling out phase, which render emulsion unsafe to use and must be discarded accordingly. The coalescence is similar to aggregation, but in this phase, the droplet fuse, increasing in size from 5 to 50 micron, appearing as yellow-brown oil droplets. Oiling out is the advanced stage of coalescence, where the large droplets fuse together, forming a distinct yellow-brown liquid layer at the surface of the emulsions. For visualizations, the figure illustrates various phase IOE destabilization previously discussed. On the left side is reversible with agitation, and on the right side is irreversible, thus must be discarded. It is crucial to assess the compatibility of medication infused with PN, as incompatibility can lead to precipitation and emulsion destabilization. Thus, EUH and ST develop and provide PN compatibility charts since as early as 2000 with ongoing updates. The lists are not comprehensive due to limited compatibility and stability studies. These charts are available in the Policy Manager at the website below for all Emory Hospital. This brings us to the last assessment question for the day. How long can IOE be safely infused in an individual without compromising its safety or stabilities? Is it 13 hours, 12 hours, 11 hours, or 10 hours? Our virtual participant, please answer when you're ready. The answer is B, 12 hours. This chart gives a quick outline of the 2017 IOE shortage considerations. For adult mild to moderate mothers, hospitalized patient receiving PN less than or equal to 2 weeks, we may withhold IOE unless it's considered essential based on clinician judgment. For adult patient that's hospitalized receiving PN more than 2 weeks, we need to provide at least 100 grams of soy-based IOE for EFAC prevention. For adult hospitalized critically ill patient receiving propofol, no additional IOE is required. There were no dose of propofol that was set on the asthma recommendations. For patients receiving home or long-term care PN receiving PN, we need to continue pre-shortage IOE therapy whenever possible. We also need to minimize IOE dose when clinically appropriate and provide at least 100 grams of soy IOE weekly. The website below the charts can provide the most current recommendation for most PN component shortage. The takeaway summary for today's presentation is to monitor lipophilic AMP medication that may contribute additional lipid calorie, such as propofol and clofidipine. Always use a 1.2 micron inline filter when administering IOE as parts of PN or separately. Review the patient's safety allergy profile prior to selecting the appropriate IOE. You want to consult the nutrition support team or IOE manufacturers for information on medication compatibility. All right, question, guys?